Well, good morning, everybody. I'm Eric Linzer, President and CEO of the New York Health Plan Association. Thank you for joining us today for our webinar, Interoperability, Implications of Data Exchange for Payors. This is one of the many webinars and policy forums that HPA hosts throughout the year to keep our members up to date on issues affecting our industry. So we appreciate you taking the time to be with us. Now, the Federal Interoperability and Patient Access Final Rule was intended to give patients access to their health information when and how they'd like it. On July 1st of this year, CMS began to enforce the new requirements to support patient access and provider directory APIs. This included policies to improve the electronic exchange of health data between patients and exchanging information with them, as well as exchanging information between health plans and providers, as well as between multiple payers. Now, today's webinar will provide an overview of the federal interoperability standards, compliance requirements for health plans, and opportunities for leveraging information to support health plan members. With us is Jonathan Shannon, Senior Director, Healthcare Strategy Team for LexisNexis Risk Solutions, an HPA affiliate. In this role, Jonathan is responsible for the organization's interoperability suite and is a subject matter expert on interoperability, value-based care solutions, and the healthcare ecosystem. Over the course of his career, Jonathan has worked as a strategic, operational, and financial advisor for a wide variety of healthcare entities, including health plans, ACOs, health systems, and primary care practices. Now, before I turn today's session over to Jonathan, we wanted to let you know that there will be an opportunity for Q&A at the conclusion of his presentation. This is an interactive session, so if you do have questions, please enter them into the chat function at the bottom of your screen, and we'll try to get to as many questions as we can over the course of the hour. We're also recording today's session, and we'll be making a copy of that available, as well as Jonathan's presentation following today's webinar. With that, I want to thank you again for joining us today, and I'll now turn the session over to Jonathan. Good morning, Jonathan.
Morning, Eric. Thank you so much for that kind introduction, and thank you all for joining and your interest in interoperability and giving me the opportunity to speak here today. I'm just going to go ahead and pull up my presentation, so please bear with me as the technology works. Here we go. So today I would like to cover three primary things. One is the regulatory environment associated around interoperability. The second is the opportunities and risks that this now presents. And then thirdly, I'd like to talk about how LexisNexis is helping support this transition and can potentially help your organizations receive this data and use it to your benefit for your members and your business operations. So what is interoperability and how has CMS articulated their desire to get there? So this is a very, very clear mandate coming out of Washington. Congress passed the 21st Century Cures Act in 2016 under the last few weeks, actually, of the Obama administration. It was aggressively implemented under the Trump administration and is being overseen now under the Biden administration. So you can see that across all of these different administrations, there is a commitment to this initiative and this effort. HHS and the ONC have established a clear direction, and they want to drive the electronic access and exchange of use of health information. They want to promote patient control over their own health information, and they want to promote the secure exchange and access of health information. As Eric mentioned, they began enforcing the requirements for the patient access API and provider APIs on July 1st of this year. And I can go into a little more detail about the roadmap on the next slide. But what you can see here from these comments and these that have come out of Washington is that there is a clear commitment to moving this forward. They really want to put the power in the hands of a patient or a member to be able to access their data at any time they wish, by any means that they wish. There's been a lot of discussion around this idea of app developers. And app developers immediately conjures up this idea of, Silicon Valley apps, like a Fitbit or something of that nature. But really what it means is anyone who can connect to these APIs and pull this data down on behalf of a member. So as we move forward, we can see here that this is a roadmap that CMS has established that lays out some of the key milestones over the past few years and in the upcoming months around interoperability. And so right now we're in 2021, and you can see that here they originally had a date of January 1st, 2021 to begin enforcement, but they exercised discretion around whether they would enforce it, and they decided to move it back until July 2021, just given the concerns around the COVID pandemic and also the technical requirements associated with getting these APIs up and running and orchestrating the data on the back end. You can see other items coming up are things like the payer-to-payer data exchange, which actually already has in the past few weeks also had an enforcement decision made around it, which CMS believes the way the rule is written today made it too complicated and too burdensome for payers to put into place. And so they have decided not to enforce this rule until new regulation comes out or new rules are written by ONC. And then in April, there is the improved coordination of benefits, which allows people to understand exactly what benefits are available at the point of care. So in addition to that, there's other things that are coming down the pipe that are clearly in view for CMS and ONC. So one is TEFCA, which is the Trusted Exchange Framework and Common Agreement. And effectively, this is the next iteration of HIEs. Basically, the Trusted Exchange Framework is a means by which there are entities called QHINs, or Qualified Health Information Networks, that can exchange data between each other on behalf of their participants and their membership. And so what happens is these entities sitting underneath the QHINs will feed information into the QHIN, and then the QHIN will pass the information amongst themselves and then pass it down to their participants. And so it's kind of like a federated model of data exchange. Another one that is a big one in line is these provider FHIR APIs. So similarly how the health plans were held to the standard of orchestrating their data and publishing them onto APIs this year, come the end of next year and the beginning of 2023, providers and EMR vendors will be held to the same standard, and they will be required and mandated to publish US CDI data or US core data, which is effectively clinical and demographic information about their membership via these APIs to make it available for their members. Now, this is above and beyond some of the current information blocking regulation that's out there today. Right now, a patient can go into any health system and say, I want my information, and the health system needs to offer that up, but they can do it in any means they see fit, whether that be, giving them an XML file, printing out 2,000 pages of clinical notes, etc. They just have to do it, and they have to give it. This establishes a clear means by which to exchange the data electronically and pass it along to a patient via an app in the same way that the payer APIs have been mandated. But there's other things that are areas of focus as well. And if we think that this roadmap that I laid out on the previous page is where CMS is done, that's absolutely not going to be the case. As I mentioned a few slides ago, this is a clear mandate. FHIR has been a commitment for the ONC. The idea of exchanging data, putting more power into the hands of a member and a patient is clearly a focus area for CMS. And there's other areas that really could use a little bit more regulation or a little more guidance from a rulemaking perspective. And so things like socioeconomic determinants of health. So folding in information about a member above and beyond their clinical information, above and beyond their claims information. So you can really get a more holistic view of the patient. And providing guidance and implementation guides on those. Guidance to help support public health. I mean, as we all know, for the past 2 years, we've been going through a global health pandemic. It made it acutely apparent that some of the shortcomings in our health systems. And I think that you're going to see some regulations coming down to support that, especially under the Biden administration. I think you'll probably see an increased mandate to all lines of business. The current rule only covers certain lines of business that are government sponsored. And so those include Medicare Advantage, Medicaid, CHIP, and federal qualified health plans, qualified health plans that are on a federal exchange rather. And so what you may see is that there may be a mandate to expand this to things like commercial lines of business, employee-sponsored lines of business, et cetera. But I think in addition to that, you'll also see some pressure from employers to get the same kind of access to this data as is available via the government-sponsored plans. US CDI version 2 and beyond. As I mentioned, US CDI is a data set that is put out under a FHIR format that covers clinical and demographic information. We'll go into that a little bit more deeply in the next few slides. But version 2 and version 3, which actually has come out recently, expand upon it, have additional areas, additional data fields, additional resources that they think would be relevant to understanding of members' clinical history. And then a mandated implementation guide of use. Implementation guide is interoperability jargon. It's basically a guidebook for how to orchestrate your data. And so there are several industry groups out there like Da Vinci and Karen who've done incredible work working with industry leaders to pull together how to orchestrate this data and present them up. And so we'll go into that again whenever we go into the data elements a little bit more deeply. But CMS to this point has shied away from mandating the use of them. They've mentioned these industry groups by name. They've mentioned the implementation guides, but they haven't said you have to use them. We've seen in our work and across the board, there are a high level of adoption of certain ones, which we think are best practices. But at the same time, there's no mandate at this point, but that may change in the future. And so what about this is different, right? So anyone who's been in healthcare for a long period of time, myself included, knows interoperability is not a new word, right? It goes along with things like value-based care and consumerism and things like that, where the term has been thrown around for a long time, and there has been iterations of it. Some successful, some not so much. But this one really is posed for success. And the reason behind it is laid out on the right-hand side of this slide. The first and foremost is patient-driven. CMS made it very clear that they wanted this rule to empower a member to own the data. So in the past, whenever data was held at an organization, whether it be at a health plan or at a provider organization or what have you, the understanding or the general understanding was that data belonged to that entity that had collected it. That is no longer the case. Now, CMS has kind of turned that on its head and said, if a member wants that data, that belongs to them. They're allowed to export that data in a reasonable fashion and use it in whatever means they think is appropriate. That is supported by the strong standards, right? So I touched upon this idea of FHIR, right? That is HL7 4.x. It's a great way of orchestrating the data in a standard fashion. And it's actually made things a lot cleaner than previously, right? So if anyone remembers interoperability, whenever you're using CDAs or even digital fax, right, to send that information, you have to hunt through lines and lines or pages and pages of data to find the relevant information. Here, you have a very strong standard that allows you to easily find the information you want or even request just specific data elements. Technical innovation is a big one as well, right? So this idea of APIs, though for many people who are technologically savvy, doesn't seem that groundbreaking, is kind of amazing from a healthcare perspective. They're not broadly used at this point in healthcare before this rule came out. And so the ability to pull data from an API and just write to it and know what you're going to get is incredible, right? It's strong. It's widely used in things like financial services to export data. And you're going to see that technical innovation flow into healthcare now as well. Privacy and security. Again, with anything healthcare or data related, the immediate fire alarms go off around HIPAA and liability and making sure that people don't expose their data in an unsafe fashion. Here, they've established a very strong workflow tool called Smart on Fire, and it uses OAuth 2 to ensure that the member who is requesting the data is actually the member that they are, and that there is a clear request at the individual level via an access token to pull down that information, and the privacy and security of that membership is ensured. And then on the flip side of that is this idea of broad access, right? Which is now, I mentioned at the beginning, the patient is the driving the force, but it's not just the patient who can receive this data. Actually, the expectation is it's not the patient who's receiving the data exclusively, right? Very few individual members can write to an API, pull down a JSON file, and understand their data, right? Very few people could do that. I don't think I know any personally. But the expectation is that they work with their apps to do this. And so whether that be a health plan publishing an app to pull that information on to their platform so they can better understand a member's clinical history, whether that's the wellness app to help encourage healthy lifestyle, whether that's a technology company that wants to pull down their claims history and their eligibility file to understand, if they're eligible for certain remote monitoring devices. Basically CMS has said whatever the patient wants to do with this data, they can do. It's theirs, and they can release it to whomever they want. And so that idea of broad access actually fundamentally changes the game here, because it's no longer this idea that at a point of care you can receive relevant care data to support a member's wellness and their care delivery of care. But now you can do it. Whatever the patient wants, you have to offer it up if they validate themselves as a valid member. So what does that mean? Really, there's multiple components to this. And so there's three intertwined areas of focus that's going to happen in a health plan. And I'm sure all of you on the phone here on this webinar have thought about probably at least one of these, if not more. And so there's this idea of compliance, right? We have to be compliant. There's a mandate out there. CMS has put the hammer down and said, you have 18 months to get this ready, orchestrate your data, right? Build out these APIs, get the technology in place. And that was a huge sprint for a lot of organizations. Some of them had a little bit of a head start because they knew where this was going, but most people, as Eric mentioned, when the interoperability final rule came out in 2020, started running to get in compliance. Then there's this idea of the new challenges associated with compliance. Going back to this idea of broad access, right? How do you ensure your membership is safe, right? Even though CMS has indicated that once the data leaves the four walls of the organization, it's not their responsibility because the onus is now on the member. There's still this very strong desire to keep this data safe, right? No one wants to be the cause of a leak of patient data. And so how do you ensure that your identity solutions are up to scratch? How do you ensure that you're validating the members? How do you build out these smart on fire workflows? And it's just a new challenge versus, putting up firewalls and ensuring that the data is safe within your four walls. And then the last one is this idea of beyond compliance. So once you have figured out all those small things that, so around compliance and new challenges, how do you start to think about this idea of leveraging this data set, right? Because this data is incredibly powerful. It's incredibly, and it was previously unavailable. And I'm going to go to the next slide where we can start to talk about that. But before we do, we have a quick poll question, and we're going to open for about a minute around where would you rate your current status of your compliance with the patient access API requirement? And there's 4 options, which are not in compliance, working on it, dealing with some challenges, or 4, looking beyond compliance and how you can leverage this data. So I'll turn it over to Eileen to open the poll. Was I closed? Okay, perfect. Thank you for that. So as those results come up, maybe we can go through them in the Q&A. Oh, it's back. Sorry.
Arlene, we're getting a couple of comments in the chat section that folks are having difficulty utilizing the poll.
Would you like me to move on and we can try it again at a later
Yeah,
date?
Jonathan, why don't we continue on and see where we get.
Okay, perfect. That sounds great. So as I mentioned here, a huge amount of new data is going to be available or is now available as of July 1st, 2021. That was previously siloed and difficult to access. And it will be, and that includes this idea of the US core data for interoperability, or US CDI. And as I mentioned, this is really demographic and clinical information that is held at a health plan. Now, there is not, the expectation is there's not going to be a ton of this, right? Unless it's a provider plan or something like that, you would expect most of the clinical data actually to be housed at the provider level. However, there should be a good amount of this, and this is a really good opportunity to understand what kind of data is there, what kind of, how it's structured, what are the various formats that can be used and things like that, whether it's SNOMED or LOIN codes or, CPT codes and ICD-10. And then all those things about how to ingest that data, because this is incredibly valuable as you think about onboarding a member. There is Karen CPCDS, right, which is, it looks like a very small box, but it's a huge amount of information. It's 6 years of claims data. So the way the rule works is health plans have to publish every single claim that they've had since 2016. And as you can imagine, that's a lot, right? Especially if someone has been with that health plan that entire time. And that includes dental, pharmacy, medical, all of those claims. And the expectation ongoing is that the data is refreshed on a regular basis. So as a claim is paid or as a claim comes in, it needs to be populated to this API every 24 hours. So that means as you call these APIs, that data should be very, very fresh and very, very relevant for that member. And then there's Da Vinci PDEX drug formulary. And this goes into basically the kind of the drug formulary that is available for that member, and the kind of drugs that they have available via their benefits. So we're going to try another poll question at this point. Obviously, this is a new format. This is a new data set that's coming in, and a lot of people have been focused on the compliance, but does your organization feel ready to ingest this FHIR data? And the answer is a simple yes or no. Okay, perfect. Great. And so the results just came in, and I'm not sure if everyone can see those, but this is kind of what we expect, right? A little bit less than 50% feel ready at this point. As I mentioned, there has been a strong focus on compliance. And so the idea of starting to leverage this information and ingest it rather than orchestrate it and publish it, this is to be kind of expected. So as we go on, so why does it matter that you should feel ready to get here, right? Why is it important that this should be the next logical step? This data is incredibly powerful, as I mentioned before. This idea of moving beyond compliance gives massive opportunities to get this data to support business operations and improve the outcomes for your members. And here we have listed some sample use cases that we've focused on to really help people or really help plans get up to speed more quickly and provide information to their membership in a quicker fashion. And actually, while I go through this, if Arlene, you wouldn't mind publishing the first poll again, that would actually be great. We can while people listen to me talk, they can select where they feel they are. So here you have the 4 use cases that we talked about, which are gaps in care, member onboarding, coordination of benefits, and pre-fill. So gaps in care is a huge issue for any health plan, right? You want to make sure that you are getting the quality metrics that you wanted to get to support your HEDIS and STAR ratings. This information, pulling in the clinical history and the claims information from a previous plan for a member, really helps you get a head start on that. Same idea around member onboarding. This is kind of a more broad approach to what you can do with this data, right? You pull in a member, and really the only information you have on them is what they filled in on the, their application, and then maybe what they put in their HRA. And we all know that that information is notoriously inaccurate because it's self-reported. And so people, when you ask people how much they drink or how much they smoke or, how healthy they are and how much they exercise, probably not the right, they're probably going to fudge it a little bit, but this really gives you the real picture. And so you can get things, you can get their claims history to see what doctors they've seen, inform PCP assignment. You can start to stratify new members at the point of enrollment based on the clinical history and the claims to do risk adjustment efforts, HEDIS and STARS, as I mentioned before, and even care management enrollment if they have some serious underlying conditions. And then you can also understand their utilization, right? When did they go out of network? Why did they go out of network? Because is it because the kind of care that they needed wasn't in the network of their previous plan, and allows you to adjust the benefits accordingly and gives you that kind of competitive intel. Coordination of benefits. We know this is a huge struggle, right? Getting information from another plan, someone's a dual eligible, or someone has a commercial plan and Medicaid or Medicare or what have you. Do you know what they've done at that other plan? This information really allows you to pull that information from those Medicare plans, from those Medicaid plans, see what services have been rendered. You can use that to inform, again, risk adjustment, HEDIS and STARS, payment responsibilities, care coordination, ensuring that, that they've had their appropriate screenings and things like that, whether they're covered by this plan or by you. And then the last one is really interesting. It's very much consumer facing. I don't know about you, but whenever I go to a doctor, I really hate the idea that every time I go to a new doctor, I have to fill out 12 pages of forms that, is information they probably should already know. Or whenever I sign up for, new programs or what have you in healthcare, I have to fill out all this information. Wouldn't it be easier if I could just click a button and say, I consent to give you access to my historical data, and then you can pre-fill that information, populate medication lists, give your medical history, give your claims history, and then that can be used, and then you can validate that with the member and say, is this still true? Is this still the medication you're on? Is this, we want to make sure that we get it for you. Actually, we saw that you took this medication, we believe this one is better. Those kind of things really allows you to have a much more frictionless member experience, and actually for them to enjoy it a lot better. And you start to move towards this idea of, a technology enabled experience. So here we go. We just got the answers to the poll questions. This is, great stuff. Looks like a lot of folks are kind of in that middle bucket, right? Which is working on it dealing with some challenges. Accounts for almost 75% of the folks, which we would imagine. 24 looking beyond compliance, which is great. And so we can start to talk about that with poll question here 3, which is, now that for those folks who already are looking beyond compliance, what are you using it for? What are you thinking of using it for, or what are you actively already using it for? For those who are working on it, what do you think is going to be the most valuable for this data in your organization? And so we have 6 choices, and also obviously if you don't have any plans at this point, please feel free to pick number 6. But we'd love to get your perspective. And obviously we'd love to go into this more in the Q&A, because unfortunately doesn't give us the opportunity for free text, but I'd love to get some more information about that. Okay, great. Thank you for that. Great. And yeah, so here we have the same results I would have expected as well. So that's great. Clinical insight is really one of the big ones. And that's a focus area, especially as the providers come online. And understanding of members' utilization and claims history are the big focus areas. I would encourage people to begin to think about removing friction from member onboarding experience. We believe that's a really huge untapped opportunity. By being able to pre-fill this data really helps improve members' experience going in through the process. So great. So what is LexisNexis's role in all this? Why do we care? Why are we here talking to you about interoperability versus someone else? We are building a solution to support this and help lower the friction of this data. So interoperability is great, right? For the past 30 minutes, I've talked to you about all of these great things that this data, this regulation has opened up and everything like that. But it's not without its flaws, right? And it's not without its shortcomings. And so part of what we're trying to do here is address some of those shortcomings and help build out a more holistic solution that can help support this flow of information. The first and foremost is there's tons of APIs out there, right? So as of July 1st, we estimate there's about 350 entities that will have published these APIs with varying levels of implementation guides and and sophistication. So what we plan to do is connect to all of them. And so, instead of, your organization having to write to every single API individually, understanding the semantic differences between them, finding the registration developer portals, registering your app and everything like that, we just do it on your behalf. The other thing is FHIR, great standard, fantastic, better than anything we've had before. However, it still has semantic differences, right? There's data in there where if you try to write an ingestion algorithm, you write to one plan, works perfectly. You write to the next one, oops, it broke. And so what we plan to do is give a standardized golden record that is the same regardless of the entity, and help address some of those differences, and then ultimately get towards this idea also of clinical crosswalks, right? So as I mentioned before, within US CDI, some of the codes that are used, SNOMED, LOINC, CPT, ICD-10, what we plan to do is work with industry groups to understand what the most broadly used and what the most beneficial ones are, and create crosswalks. So if someone were to publish, they have their data all in LOINC codes and SNOMED is more useful, we'd develop a crosswalk for that particular data element and say, here you go. Now you can have both SNOMED and LOINC. So you have the original data and also the crosswalk data. So you can ingest it in the way you see fit. The third thing that we're planning to do is enrich these data. So as you all may know, LexisNexis has a huge repository of data on members and providers and things of that nature. And we can use that to help create a more holistic member profile. So we can add things like SDOH, which an IG has not been developed for yet or approved yet. We can add, so you can not only have the clinical and claims information, but you can also understand if a person is struggling because they're in a food desert, or they're socially isolated, or they can't afford their medication. So you can appropriately couch the care coordination activities to address that issue. Additionally, we have a lot of information around contact information. All of this data coming from health plans, especially for this audience, is going to be historical, right? If you're calling it a health plan that someone used to be at, and then now they're yours, it's going to be outdated, right? So either they had it last year or they had it 6 years ago. And so, or somewhere in between, right? Obviously. So we can help provide updated addresses, updated phone numbers, updated email addresses, things like that. And then lastly, we can provide a UCAN identifier. We have this thing called Lex Id, which can really help you supplement the internal identifiers you have at your organizations to help link to a single member. And you can help understand, oh, Jonathan Shannon is the same as John Shannon, who's the same as JR Shannon, who was in that plan various times. And so we can help to tell you that. And you can use that with your MDM solutions to link up and create a more holistic member profile. And then the last item is we have the single integration, right? So I'd mentioned we're connecting to the manifold of APIs at this point. Now you only have to write to one API. There's one capability guide. There's one point of contact that you can deal with. And that's what we're helping. And we do this everywhere, right? So within our healthcare organization, we connect to tons of different data sources and aggregate them. But outside of ours, one example is we connect to all the county courthouses where there's tens of thousands of, or there's hundreds of different courthouses. And there's varying levels of semantics, and we organize them all for the car insurance or industry. So this is something that's right in our alleyway. And we think we have a right to win here. So great, Jonathan, you've talked all about regulation. You've talked about, what LexisNexis is doing. You've talked about the opportunities and risks. How does this actually work? And so Smart on Fire, I'm going to walk you through an example of what it looks like. If there's any technology folks on the phone, please don't judge me too harshly. I'm not a technology person, so this is illustrative at best. But I think it helps paint a picture of what what it looks like to work with us to get this information. So starting with the person right in the middle, Plan A needs more insight on member A to improve their member onboarding experience. So they start to work with member A. And remember what I said about this regulation. It's all member driven. So the member has to be involved in every single call for this data, and it's at the individual level. So they say, member A, would you be willing to give me that data? Or would you authorize me to act on your behalf as an app developer? Member A says, great, let's go. I used to be at Plan B. I'm going to log in. Authorize myself and authenticate myself and authorize the release of data to you. Plan B says, okay, great. You're obviously a valid member. You've established Plan A as your intermediary and your representative. I will pass what we call an access or a consent token back to them. And they can call our API and get the data. This is where LexisNexis comes in, right? Plan A passes the access token to us and says, LexisNexis, can you go fetch this data for me on my behalf? And we say, absolutely. So we'll go back to Plan B, give them the access token and say, please give us the data. Plan B says, okay, great. That's a valid access token. We'll give it to LexisNexis. LexisNexis pulls it in, ingests it on our platform, normalizes, standardizes the data, enriches it as you see fit, and then passes it back through our single API back to Plan A. And that's how the flow works, right? So if you were to do it without us, it would be steps 1, 2, and 3, but you'd have to do that for everyone. If you do it with us, it's all of the steps, but we can do it for regardless of what Plan B looks like. We can do it for C, D, E, and F, and G, and so on. So that's really how the process works. But as you can see, the member is really at the heart of how Smart on Fire works. And it's driven very much by them authenticating themselves and authorizing the release of data to any entity that exists. So with that, obviously I've talked about the solution that we have here. If you'd like to learn more about this solution or any other solutions, because I saw there was other people saying they were struggling with identity solutions, which we also have answers for. If you'd like a representative to contact you, please feel free. And this is this should be a private poll. So we'll just collect this information and contact you separately afterwards. But if you wouldn't mind, please filling this in and we can reach out to you if you have any questions.
All right, great. So Jonathan, thank you for that presentation. Hopefully folks found it useful and informative. We're going to open up the Q&A portion of today's webinar. And as a reminder, if you do have questions, either enter it into either the chat function or the Q&A function, and we'll get to as many questions as we can really in the next 20 minutes or so. I'm going to kick it off with a couple of questions. Jonathan, you talked an awful lot about the member being in charge of his or her their data. How do you think most healthcare organizations are going to handle the member consent component to this? Because obviously none of that can start until the member says yes, you can access my data.
Yeah, and so CMS and ONC, that's a great question, right? Because it's like nothing we've done before, right? Which is usually it was, I want access to healthcare data. The answer was no, unless you're a provider and you're providing care. CMS and ONC have actually done a really great job establishing this idea of Smart on Fire, right? So they've laid out guidelines exactly about how this process works, right? And that was kind of like the last slide I walked through a little bit. And if you go to healthcareIT.gov or anything like that, they have explicit guidelines about how to generate create that member consent workflow. And so really it's based on this idea of OAuth 2. a member logs in. A lot of health plans we see are using their existing portal to to do the authentication. And then what happens is once they've authenticated themselves and identified themselves as a valid member, that access token is passed back to the member and also to the registered entity that's acting on their behalf. And whether that's a health plan or an app developer or what have you, that token is what is used to hit the API, and then that token will say, includes information about who the member is, what data they've given consent to share, and to what entity they want to share it with, and then that information is fed back into the plan that holds that information. So Plan B in my example, and that is passed along.
Great. We did get one question about whether or not copies of the slides will be available. As a reminder, as I said at the outset, we are recording today's session, so we'll be sending out a link to today's program along with a copy of Jonathan's presentation following the session. In addition, as part of that, we'll be sending out a questionnaire on thoughts, feedback on today's program, and including going back to Jonathan's last point. If you wish to be contacted, certainly provide that information. Jonathan, a couple of other questions sort of into the substance of how this is all going to work. How are plans going to be able to collect information from patient access APIs? Are they going to need permission, or is it going to be something where, if it's existing data, how best are they, should plans be thinking about collecting, accessing, and capturing this information?
Yeah. I'm starting to feel like I'm sounding like a broken record, but it's all about the member. So that's honestly, so whenever you think about this data, right, this data is mandated to be available, right? And that's part of the reason that we've gotten into the space, and we think that it's an exciting space to be in. Plans have to publish these APIs, right? If they have these lines of business, whether they're Medicare Advantage, Medicaid, CHIP, or federal qualified health plans, this data needs to be available. It needs to be orchestrated. It needs to be published via an API. How can they access it? It's engaging with the membership. It's developing that point of where you can ask them to make a decision. And so, obviously consult your legal teams about how you encourage members to give you this access to this information. But it's basically offering them a question, and you say, would you be willing to allow me to access this data on your behalf? And a lot of people, if they make it appealing enough, whether it's through that pre-filled use case or what have you, or maybe through encouragement of lower premiums or again, do not take this as legal advice, please. Lower premiums or encouragement of wellness, things like that. You can encourage the member to say, yes, I would absolutely allow it because it would make my experience better. And then once you have that member's agreement, you can ask them to authenticate themselves with the plan you want to get the data from. And that will allow you to get that data, and you can use it for your own purposes. So that's determined by the terms and conditions you establish with your member. And so if you say, I'm accessing this on your behalf and I'm going to use this data to improve your care, to build analytical models, to do whatever it is, as long as it's reasonable, right? That's what will dictate the use rights of that data.
And we got a question along those lines, which I think we've captured the bulk of it. I think the question about assisting members in consenting for this information, Jonathan, it sounds like really communication, outreach to the member is going to be critical. There's probably multiple touch points where plans are going to have to outreach on this. I think one piece that that our industry probably needs to think about, and to your point about either incentives or lower premiums, certainly New York does not allow that kind of sort of incentivizing the individual. We certainly have challenges related to anti-inducement, the rebate rules here in New York. However, there's been ongoing conversations about items that seek to support wellness or benefit the patient, might be things that the state ought to be reconsidering. So I think that this has been a helpful conversation so far.
And just to add to that, I mean, there's also times where it makes sense to engage the member, right? If it's in the middle of their cycle and all of out of the blue, you send an email being like, can I pull your data? They probably are going to say no, right? Whereas whenever that's part of the reason we encourage this idea, thinking about this idea of member enrollment and onboarding or use case, because at that point, it kind of sometimes makes sense. It's like, we can actually fill out this information for you if you give access to this data. And so I don't know if that falls under inducement or if that's a value added service or what have you. Again, not legal advice. I'm not a lawyer, but and we think that that's a natural place by which you can really encourage people to say, oh, actually, that makes sense. Yeah, you want to know more about me so you can give me better care. That's great. I'd love that. Yeah.
Great. So we're getting some, a couple of other questions that have come in. Should or can the member limit what data can be allowed for the patient, for the payer to get? For example, sensitive conditions, or limiting which conditions or information the payer may be able to access.
Yeah, so that's again established at the relationship between the plan and the member. It's defined by the terms of service and the kind of data they can set. The way FHIR is set up, from a technical perspective, you absolutely can select the resources that you want to do. So if you only wanted to offer up, here's my demographic information and my BMI, because it's relevant for someone who's a wellness company, right? Or something like that. Again, I know that's not the audience here, but you can definitely do that, and you can establish that, and that can actually give some people ease about the kind of data that you're collecting. You can establish certain, what they call resources or profiles within FHIR that can be fetched on behalf of a member, and our system supports that as well. But yeah, it's really determined at that point where they authorize a release of data. And so what you ask them to fetch for you will dictate what they pass back. And so there are certain items that are outside of the realm. And I'm not exactly, I can't think of them right now off the top of my head. But this is a pretty comprehensive data set. You get a lot of information about a member if they give you blanket access to the data.
So picking up on that theme of access to the data, the scope, the amount of available data. Another question that we've gotten in is about claims information, its availability, whether the member is still active with the old plan or is no longer with that old plan. Can you talk a little bit about what's going to be available, payer to payer, if the member is not currently active, and how much claims information or clinical data would be within that scope?
Yeah, absolutely. And so that's a really kind of cool thing about this mandate. But I can imagine if anyone's on an IT team at a health plan, they're probably rolling their eyes at me. That's not cool. It's a ton of work. But a lot of data had to be orchestrated for this, right? So when I was talking about Karen's CPCDS, that is your full claims history, regardless of its clinical, dental, pharmacy, and it goes all the way back to 2016 is the requirement, right? So if someone is not active today, so let's say you had a member enroll in your plan in November and they come on 2022, you call that API, you still get all the claims history from 2016 through 2021. You get everything. And you get everything that the plan has on that member, from a demographic and clinical perspective as well. Everything they've ever collected at that point of time, you get it. And so it's a ton of information. If they're active, that's the coordination of benefits use case that we thought that we presented. It's as of 24 hours ago. So whatever claim is paid 24 hours ago, or a claim comes through 24 hours ago, you get that information. And so it's a very, very onerous responsibility on part of compliance. But from the idea of utilizing this data, it's a very, very rich data set to access and to use for your members.
So picking up on that theme and going back to data as far back as 2016, are there concerns that plans should have about the data that they're receiving, trust in the data, its accuracy, verification? I mean, it sounds like whatever's there, can get shipped over depending upon how the member, to the extent that the member may consent. But if there are gaps or missing information, how much security should plans have, or trust in the data that gets exchanged between and among payers?
Yeah, and so it's a very valid concern. The mandate requires it be as accurate as as possible, right? And so there is a strong, like if you just offer up whatever you have and without really putting any effort in, CMS will find you, and they know that, right? Like, and they will say you're not doing a good job, and you're not living up to the spirit of the mandate, right? And that's when the enforcement comes into play. That being said, you should always take a critical eye at data that's coming, especially historical data. Is it comprehensive? As I mentioned, some plans struggle with this idea of member continuity, right? So if I signed up under John Shannon one time, I left a plan, came back to a plan, signed up under Jonathan Shannon under a new address, etc. Is that data the same? Will they link those profiles and know that I'm the same person? Some plans will, some plans won't. And so whenever it calls, it depends on the authentication that I'm using, right? And so the expectation is that on the back end, the data is orchestrated properly. The FHIR standard makes that much more prescriptive. It makes it much easier to understand what's required and what's not. But always understand that there may be gaps because of those ideas of member matching, but if it's available and it's tied to my profile, it's going to be there.
And then Jonathan, picking up on the third poll question that looked at things such as reducing friction for members in the onboarding process, can you provide maybe some insight for some of the plans or other healthcare organizations that you've worked with on how they're planning to utilize this data to support the member, reduce friction, but also engage around clinical quality initiatives?
Yeah, absolutely. And so one of the things that I don't know if anyone has experienced this whenever they go through the healthcare ecosystem, but whenever you sign up with a new healthcare entity, whether it be a plan or a system or provider, whatever it may be, generally speaking, they're pretty sophisticated. They've got a lot of programs they want you to participate in, right? So you get outreach from member services being like, welcome to our plan. Here's your benefits, things like that. You get outreach from the pharmacy saying, here's our closest pharmacies. Here's the, these things that you're interested in. You get outreach, if you have comorbidities or serious health conditions, you get outreach from the care management department. You have to work through your way through utilization management if you've had some high cost procedures and that you need to keep it going forward. Things like that are the way that you can help remove friction by having this data in-house, right? So instead of going in blind and asking the patient or the member to give up this information or offer up this information or engaging with providers, because we all know how much providers love dealing with health plans that questions, you can just get this data from this API because it exists. And then instead of whenever you're reaching out, it's a much more directed outreach. It says, look, I see you have diabetes. There are several wellness programs in your area that offer healthy food, also exercise and things like that. And it's much more targeted, right? It's much more focused as opposed to saying, can you tell me about what you have going on and we can help figure it out together? Instead of that, it's very similar, and I hate to use this analogy because it's getting so much bad press at the time, but it's these personalized ads, right? That they collect, if you have access to the information about a member navigating through your website or navigating through your ecosystem, you can give them much more personalized responses and answers, and you can outreach them at the time that it's most relevant to them. And that's how I see this data being used and how people are thinking about it. Another big one is you have people coming in who are underdiagnosed and you want to optimize risk adjustment, right? So that's a huge one where you see, someone's, been admitted to the ER several times, with not a real diagnosis. You see that they've seen a pulmonologist. You see that they've, they've collapsed or what have you, or that they are regularly going to, they're jumping around doctors. That person may have COPD that's gone undiagnosed. And then you can use that information to do risk adjustment and get your appropriate reimbursement for that person. But at the same time, also outreach to them and help manage their cost of care and make sure that they have an optimized outcome and no more acute events.
Right. And let me remind folks again about utilizing the Q&A or chat function to ask questions. So then, Jonathan, one other question that I have, for, let's say, for example, an individual who has a chronic condition, goes from one plan to another, one of the concerns that we hear oftentimes from legislators or provider or consumer groups is that the individual then needs to go back through the process of getting authorizations for their medications. Do you foresee these rules as being a way, provided that the member consents, as a way to reduce some of those some of that time and requests both from the provider and the member?
Absolutely, and so they can help accelerate that pre-auth process quite substantially, right? Because you now have all that data, what services were authorized in before, whenever they were at another plan. Additionally, part of the roadmap for interoperability is at the provider end, health plans will have to offer up the pre-authorizations that exist for that plan via these APIs. And so that actually will help at the point of care accelerate that discussion as well, versus them saying you probably need XYZ procedure. Let me go reach out to your plan. I'll send them over my clinical notes and they can review it and get back to me in 72 hours or what have you. And they can just hit the API and say, is this already authorized? Oh, it is. Okay, great. Let's go. And we can get you into surgery today. So those kind of things, absolutely. It is one of those things that will help remove that friction if that data is ingested into the appropriate teams. And I think that's another big thing is this data has applicability across a health plan, right? So membership services, care management, utilization management, in the finance organization, et cetera. There's a lot of value that can be derived out of this, and it requires a lot of stakeholders to come together to figure out how to best use this data for their membership.
And then we've got one final question. I think it's a little technical. The question being that does LexisNexis help extract the data between among plans and passes it on? But who's hosting the data for the member to see?
Yeah, so we are acting as purely as an intermediary. So we are the pipes, for want of a better word. We connect to the APIs and we pass along the information. The data is the members, and if they consented to share it with you, it's yours. It's not ours. And so I think that's important to note, because we do have a history of collecting data, but at this point, we are not collecting any data on the members. It's passed through and then it's deleted from our cloud-based platform.
Well, we're getting up against the noontime hour. Jonathan, I want to thank you again for taking the time today. This has been an interesting and insightful discussion. I want to thank LexisNexis Risk Solutions for supporting today's program. We hope you all found this session informative. As a reminder, registration for HPA's annual conference, How Do We Ensure Innovation is Accessible to All, is now open. This year's program is taking place November 16th through the 18th as a virtual program, so we hope to see you all there. In the meantime, we'll be sending attendees a copy of today's presentation and an evaluation form to give us feedback on today's webinar and any suggestions that you may have for future programs. So again, thank you all for taking the time today. We know how busy your schedules are, and carving out some time to join us. We really appreciate it. So thank you again, and we hope you have a great rest of your week. Thanks, everybody.
Thank you all for having me. Take care.